So how does that conversation go? What happens when there's a difference between physicians' clinical judgment and price is getting pushed back at you through the phone? Describe the whole process for me.
Certainly many patients can do well on bevacizumab dosing. In my hands, they often need more frequent dosing, but in patients that are incomplete responders and have persistent fluid that is causing lack of optimal visual acuity outcomes, I don't hesitate to switch those patients over.
Okay, and then do you get pushback when you do that? Do you get phone calls, or do you have
Yes, so internally we actually have some plans that we as a group are really very resistant to using an on-label drug, because we've been told very clearly by the payers, at all costs, please avoid using on-label drug. And we try to respect that. Because as you said, someone else is paying their bill. And so we feel like we do need to have some conversation with our payers, and we try to stay engaged with that.
But sometimes the hurdles are a little unreasonable, certainly. And in some cases where we've had a plan come into our state that required visual field testing, which is not a part of monitoring wet AMD, or document of improvement, as Charlie mentioned, just keeping things even keeled and keeping the ship sailing down its current path is a win in this case. And so when you get hurdles that are placed in front of you like that, to even maintain treatment, much less switch, that's a challenge to try and take care of those patients.
And let me drive this a little harder. Are you saying that there are plans that when you call up and say, Mr. Jones is getting much worse, and he really needs to switch over to one of these two drugs that are on label, they will push back and say no?
They'll put many obstacles in the way. Let me give you some examples.
Sure.
They'll say we require a lot of documentation, and they'll sit right back and say no, and then we'll submit it again, and more documentation. Eventually they might say yes. The challenge is if they say yes too many times, the next year you'll be told you can't see their patients anymore.
Oh, so they'll just throw you off the network.
Right.
So
Which
at
we
the end
have
of it, and I heard you say you have been thrown
Yes.
off the network. You're just a bad guy.
You know, I hope not. I try to treat all my patients as if I want to be treated.
That's so unlikely because there's so few of you, but seriously.
Have you ever had that happen to you?
We've never been thrown off a plan, but certainly, you know, because we're a very busy retina practice, I don't see patients for just minor retina problems. Everybody that I see is they're being treated actively for a disease. Everybody that I see is facing vision loss, essentially. And so in that realm, when you compare me to some other providers, I may be more expensive. And certainly if I'm using more branded agents, I'm going to be a target. And we've had discussions with payers in the past. We haven't ever been kicked off a plan, but we certainly have been put on notice, essentially, that we need to continue to try and use cheaper medication.
Yeah. You know, this has been a tremendous discussion. Yeah. And before we end it, what I want to do is give each of you an opportunity just once, without interruption, to give us some summation of what you think, where we are with this, where we might want to go. Dr. Dehnel first.
So I think that there's a personal tie here that I have to this issue, and that's with a relative who has this condition, who receives monthly injections. And I think it's a really important topic and probably under-recognized by all the payers and as well as many of the clinicians in the country. So I see one outcome of this being that we helped get this message out going forward.
Okay, and that's great. Dr. Johnson, you're up.
Yeah, I think just having dialogue, having conversation, understanding the perspective of the other side, if you will, is very important, because I think we're closer on this than what sometimes it appears.
Okay, Dr. Nielsen.
Well, I'm just grateful to have the opportunity to treat these patients who suffer from this disease. The economic burden of this disease, the burden it has on individual lives, is substantial. And I'm grateful for people that partner with us in doing this and enable me to see patients. I became a physician because I wanted to take care of people and improve their lives. And unfortunately, there are some distractions to that with dealing with some of these issues, but I'm certainly grateful that I have the opportunity to do that.
And Dr. Wykoff, we're going to give you the last word.
You know, it is a privilege to be able to care for patients and to be a shepherd of their vision. And I love conversations like this. We need more open dialogue. We need more conversations about how we all can get to our shared goals, which are better outcomes more efficiently for patients.
All right. You know, from my perspective, I've been in the business a long time. One of the most amazing things is the conversation that we're having is about drugs that actually work. for diseases which in the past we had nothing. And this is a great kind of discussion to have, and I want to thank you, all of you, for being here and being as open about it and disagreeing as openly as you did, because this is the way we make progress, in my view. Of course, I want to thank you for joining us as well, and I hope you join us the next time. I'm Dr. Peter Salgo, and I'll see you then.